on each side, and about 10% of blood from those main arteries goes to each kidney. If you look at the renal artery picture, you can see that that little red artery keeps getting smaller and smaller and smaller throughout the kidney. And then if you look on the right, it'll show you a small cutout of a nephron. The nephrons are the filtering unit of the kidney. That's what we're worried about when we talk about chronic kidney disease, is how are those little nephrons filtering. So when we talk about kidney disease, there's 5 stages of kidney disease that we classify people in if they have kidney damage. Stage 1 is a patient with a normal glomerular filtration rate and some sort of damage to their kidney. So let's take a minute and talk about what the glomerular filtration rate. I always tell my patients in clinic, it's a big word, but what I want you to think about is it's really a number of how much blood is being filtered by those tiny little nephrons in the kidney per minute. And the glomerular filtration rate is based on your age, your weight, your height, whether you're male or female, and on your ethnicity, mostly if you're African American, if you're Caucasian. Men tend to have more muscle mass than females, so that's why there's a calculation difference. And African Americans tend to have more muscle mass than Caucasians, so that's why that calculation difference comes in. So when you go to your doctor and labs are drawn, they draw something called the creatinine. That creatinine is also taken into that calculation. And when you look, it calculates that GFR number that you see on the right-hand side of your page. So patients with stage 1 kidney disease have some sort of kidney damage. This could be a hereditary thing, something they're born with, maybe somebody who's only born with 1 kidney, somebody who has a hereditary disease like polycystic kidney disease. You may see blood in your urine or protein in your urine when you go to the doctor's office. But these people normally have a normal glomerular filtration rate of greater than 90. Stage 2 kidney disease is when patients have some sort of kidney damage, as we talked about in stage 1, but their GFR has decreased from anywhere between 60 to 89 mils per minute. The majority of patients I work with are in stage 3 through 5. Stage 3 kidney disease is described as being moderate. Patients have a glomerular filtration rate of anywhere from 30 to 59. Stage 4 patients are classified as being more severe with a GFR of anywhere from 15 to 29. And patients with stage 5 are usually less than 15. And when the GFR gets low enough, patients usually end up as end-stage renal disease and end up on dialysis. So let's talk about some common kidney failure prevention strategies. You always hear, drink plenty of water, drink plenty of water. And it's hard for all of us, but one of the reasons why we want you to drink water is we want to keep your body hydrated. Nothing is harder on the kidney than being in a dehydrated state. So we always talk about drink plenty of water. I tell my patients, I want your urine to be a light yellow color. That tells me throughout the day that you're drinking enough water. It's going to be a little bit more concentrated in the morning, but throughout the day, you should have light yellow color urine. We want to talk about control of several different issues. Hypertension, blood pressure control. This is huge. Glucose control and weight. In the kidney world, diabetes is the #1 cause of kidney failure, and hypertension is #2. High blood pressure causes hardening of the arteries that lead to the kidney, and within that kidney, in the little capillaries that feed into the glomerulus in the nephron, can also become damaged with high blood pressure. So blood pressure control is vitally important to your kidney health. In patients with diabetes, glucose control is important because high glucose levels can affect the capillaries within the glomerulus. When those capillaries are affected to the high levels of glucose, they become leaky and they start leaking protein into the urine. That can further damage the nephrons and cause worsening of the kidney disease. Weight, inactivity, all play a role in hypertension, glucose control, metabolic syndrome, high blood pressure, lipid control. So we're always striving for a healthy weight, healthy diet. So let's talk a little bit about labs. When you go to your doctor, do you actually know what's being drawn and what the doctors are actually looking at? So one of the things that we get drawn is something called a creatinine. Creatinine comes from our muscles. As we move around day to day, our muscles are constantly building up and breaking down and releasing creatinine into our blood system. That's what I tell patients, gives your urine that yellow color. It's consistently made, so it's a pretty good indicator of how well the kidneys are filtering. It's not something we need to keep in our body. So the creatinine, normal creatinine is about 0.6 to 1.1 milliliters per, or milligrams per minute, or milligrams, sorry, per deciliter. You want that creatinine to be lower. You want your kidneys filtering that creatinine out as much as it can versus keeping it. We look at the blood urea nitrogen level. That comes from the protein we eat. When we eat proteins such as meat, legumes, peanut butter, all that breaks down into nitrogen, and nitrogen is one of the waste products that we measure. We talked a little bit about the glomerular filtration rate when we talked about the stages of kidney disease. That's a calculation based on the creatinine along with the other parameters of your height, weight, age, and ethnicity. The kidneys actually manage your blood count. Remember I told you about 10% of the blood goes to each kidney? That kidney can tell how much oxygen is being carried by those blood cells. If the kidneys don't see enough oxygen, it stimulates that erythropoietin to tell the bone marrow to make more blood cells. So if you're anemic, one of the things your doctor might want to check is how your kidneys are doing. One of the easiest ways for us to screen for kidney disease is to look at your urine. When you submit a urine sample, we send it down to the lab, and what we're looking for are blood, which is also called hematuria, protein, and albumin. Albumin is just a form of a protein. So at this point, what I really want to emphasize is good follow-up. Follow up with your doctor, go in for your regular physicals, ask questions. If something doesn't seem right, you're not feeling well, don't put it off. Call your doctor, get in to see, get your labs done, know what your labs say. If you have a question about your labs, ask your doctor, ask your provider, ask your nurse practitioner, ask your PA, ask somebody. Don't rely on information that you may get from a secondhand source, from a cousin, from a friend. Go to the experts and find out what those numbers mean if you don't understand. So one of the things I want to talk about here, just as a quick note regarding to women, is on the urinalysis results. Sometimes, based on a female structure, blood or protein can mix into that urine, either from our menses cycle, maybe we have small tears in our private area. All of that can mix into the urine. So if you come out with a urine result that has microscopic hematuria, which is small amounts of blood that can't be seen on visualization, you want to follow up. You want to get another urine. You want to see if that blood is there on another visit. Don't put it off by saying, oh, it's just an inappropriate sample. Maybe I scratched myself. You want to make sure that you are following up, that if that blood or protein is actually in your urine, that it's actually there, and you want to follow up with somebody to see what is there. The earlier you can detect kidney disease, the better off you're going to be in the long run. So let's take a minute to talk about the consideration of over-the-counter medicines in relation to kidney disease. We got a couple medications up there that we routinely take as Americans, actually anybody, Tylenol or acetaminophen. Acetaminophen is cleared by the liver, so it's safe as directed. We recommend no more than 4 grams of Tylenol between all sources to be taken in a day. So be careful if you're taking Tylenol and you're taking maybe a narcotic pain medication that has acetaminophen in it. Also, you want to make sure that you're not overdosing and hurting your liver. We talk about aspirin. Aspirin is considered a non-steroidal anti-inflammatory. Aspirin can cause an increased bleeding because it affects the platelets, and it can cause some GI upset. Talk about some over-the-counter calcium, Tums, upset stomach. The only concern if you're chronically taking calcium more than recommended or because of upset stomach, increased calcium levels can cause muscle weakness, muscle tremors. It can lead to increased kidney stone production because a lot of kidney stones are calcium-based. So let's talk a little bit about NSAIDs, non-steroidal anti-inflammatory drugs. These are women's best friends. These are your ibuprofen, your Advil, your Aleve, your naproxen. These are things that I feel that women take on a day-to-day basis. The chronic use for headaches, increased menstrual pain, chronic pain. NSAIDs can be abused to a point that they affect the structure of those nephrons. Remember when we looked back at that first slide, the little nephrons within the kidney? There can become inflammation in those nephrons, and that can lead to chronic long-term kidney disease. So one of the things that we want to talk about is, how can you prevent over-the-counter medications causing kidney disease? Well, you definitely want to limit your use. Use it when you need it. Limit the amount you're taking and follow the package prescribed, and also the duration that you're taking it. We recommend no more than 10 days of over-the-counter medication use before you need to see a provider. Consult your medical provider, consult your nurse practitioner, your PA, your doctor, if you're concerned about your use. We want to make sure that you're hydrated while you're taking all these medications, especially the NSAIDs. You want to make sure that they're being flushed through your system. So some of the things that we don't always have control over, or some of the things that we do have control over, is diagnostic procedures involving contrast dye. You go to your doctor, you're having headaches, maybe you're having a rotator cuff problem in your shoulder, a knee problem, and your doctor says, okay, I want you to go have an MRI or a CT scan. Be aware that if you have a problem with your kidneys and you have some degree of chronic kidney disease, or even if you don't have chronic kidney disease, these procedures use contrast dye. And when contrast dye is injected into the body, it helps the imaging light up on the screen, as you can see on the right-hand side. The darker areas are where that contrast dye is going through those arteries and lighting them up so that we can see the shape and size of them. That contrast dye will settle out in those glomeruli of those nephrons and cause them to not work and ultimately die. So one of the things that I recommend is that if you need an MRI, if you need a CT scan, ask your doctor, do I need to have this with contrast? Are you at a new doctor? Are you at a rehab facility? Are you at a sports medicine doctor? Do you need to have contrast with those studies? Now, one of the things you obviously can't have a worry about is a cardiac cath. A cardiac cath is if you're having chest pain and you're going into the cardiac cath suite. They use dye to inject into the heart so that they can see the arteries, and if there's blockage. Unfortunately, your heart living is more important than your kidneys at that point. But what they're also going to want to do is make sure that you're adequately hydrated. And if sometimes patients who are farther along in kidney disease may get some kind of temporary dialysis immediately after a procedure to help remove some of that dye. So let's talk about some family history risk factors. Diabetes. Like I said, diabetes is the leading cause of kidney failure in the United States. Diabetes has a very high prevalence. It's our body's inability to regulate our sugars. Diabetes does have a strong family history. Best thing you can do is keep yourself active, keep yourself moving, keep your weight in check. Make sure that if you are diabetic, that you're monitoring your glucoses and that you're monitoring your kidneys and how they're doing. High blood pressure, like I said, number 2 cause of kidney failure in the United States. High blood pressure is a hardening of the arteries. So what happens is the arteries that are directly feeding into the kidney, the renal arteries, become hardened and they become stenose, so they can't be as pliable. And that hardening also affects the small little vessels within the kidney and the little capillaries. The blood pressure also affects the capillaries that they become leaky. And when they become leaky, they leak protein and blood and other substances into the nephron that ultimately come out in the urine. One of the things you really can't do too much about is focal segmental glomerular sclerosis, FSGS. This is scarring of those glomeruli of the nephrons. That is a hereditary disease. Polycystic kidney disease, also a disease that's passed on. Polycystic disease almost, in my experience, almost always progresses on to further stages of kidney disease and ultimately to dialysis, although it is usually a slower progressing disease than diabetes or high blood pressure. I always get this wrong. Nephronephritis, inflammation is scarring. When we talk about NSAIDs and NSAID abuse, NSAIDs can scar those nephrons, and that's what ultimately leads to those nephron deaths and decrease of your kidney function. And some congenital abnormalities of the kidney and the urinary tract. So some of those examples would be children who are born with hydronephrosis, which is a buildup of fluid within the kidney itself. That buildup of fluid affects the nephrons. That buildup can either cause an obstruction or it may not. That obstruction will cause more fluid to build up into the kidney and cause those nephrons to be damaged. Cystic disease, any disease that causes cysts to be formed. As we age, we all start to form cysts in our body, and it's not unusual for you to go to the doctor and have an ultrasound done of your kidneys and see maybe 1 or 2 cysts as we progress in our age. But young children who have a large amount of cysts on their kidney, you know, that those cysts rupture, they hurt the nephrons, and that ultimately leads to kidney problems. Some kids are born with defects of the kidney tissue and cause further kidney damage, and any metabolic diseases that can affect the kidney. And the best thing for that is just, you know, good relationship with your pediatric doctor to follow up on your kids and make sure that they're as healthy as they can be. Okay, we talked a little bit about this. Obesity as a risk factor. So, you know, obesity is the leading cause of diabetes. Obesity causes problems with high blood pressure. Inactivity in itself can cause metabolic syndrome, problems with lipid levels. With all of those affect your kidneys. So we really recommend, you know, keeping active, keep moving, follow a heart-healthy diet, low-sodium diet if you need to, and any kind of diabetic diet if you need to, if you have diabetes. Smoking, you know, we harp on this all the time. If you smoke, stop. Smoking is the leading cause of kidney cancer. Kidney cancer is usually an isolated tumor within the kidney. It's usually found when blood is seen in the urine and then a scan is done and the tumor is seen in the kidney. The only treatment for kidney cancer is to have that tumor removed. So what happens is the surgeons go in, they cut out healthy tissue around that tumor to get that tumor removed. And depending on where that tumor is, sometimes the whole kidney needs to be removed. So you're taking out a lot of healthy tissue to get clean margins to get the cancer out. So smoking also causes hardening of the arteries. It causes coronary artery disease. We've talked about that. That leads to hypertension, and that leads to kidney disease. If you have a history of stones, kidney stones can cause obstruction. Obstruction causes backup of the urine into the main part of the kidney and causes what we call hydronephrosis. So what we would see on an ultrasound is a big pocket of fluid within the main structure of the kidney. That hydronephrosis, if it's not relieved, further damages the kidneys. You may not notice that you're decreasing the amount of urine production. Your urine may still be yellow because your other kidney's usually going to pick up the speed. How you guys doing? Okay, so let's talk about toxic substance. We already talked about medication and dyes. Let's talk a little bit about illegal drugs. Marijuana, cocaine, all of those raise your blood pressure. They cause vasoconstriction within the kidneys, which ultimately leads to kidney disease. Excessive alcohol use. I'm not here to define excessive alcohol use, but excessive alcohol can cause those glomeruli and those nephrons to be less efficient at filtering. Women who have, or anybody who has frequent urinary tract infections, those infections can become, they can move up the kidney structure through the ureters and into the kidney itself. That's called pyelonephritis. Pyelonephritis is very painful. And that pyelonephritis can affect the actual structure of the kidney and damage those nephrons. So let's talk a little bit about oral contraceptives. A lot of young women and women in general are on oral contraceptives. The reason we worry about oral contraceptives is, one, they can cause high blood pressure, and two, they can cause blood clots. Now, we always worry about people talking about blood clots to the lungs, blood clots causing strokes. You can also have a blood clot that goes to the kidney through that main artery and cause an infarct or a deadening of the tissue within the kidney. Pregnancy. Pregnancy can cause a whole host of problems. Pregnancy can induce hypertension. Pregnancy can induce gestational diabetes, which is a risk factor for diabetes down the line. Pregnancy can cause preeclampsia, which is a condition where women have edema, high blood pressure, and protein in the urine. That preeclampsia is a risk factor for kidney disease. Eclampsia is when that preeclampsia condition progresses to seizures within the woman, and the only cure for preeclampsia or eclampsia is delivery of that baby. Other disease processes. Lupus, a disease often, an autoimmune disease often found in women, can cause lupus nephritis. Let's talk about medications. Sometimes if you go to your doctor, you may get started and you have high blood pressure. One of the first things they start you on is a diuretic. That's their first line. Diuretics can cause dehydration. It seems counterintuitive that you are taking a medication to get rid of fluid, and then I am telling you to make sure you keep yourself well hydrated, but that's the case. So if you're taking a diuretic, don't think that you need to skimp on your water to make the diuretic more effective. Make sure you're keeping yourself hydrated and your urine's a light yellow color. One other medication that's started routinely for high blood pressures are something called ACE inhibitors. ACE inhibitors usually one of the first lines. They are wonderful in most patients who have kidney disease. They actually reduce the blood pressure in those little capillaries within the glomeruli. But in some patients, those ACE inhibitors can actually cause the creatinine to increase. So I would recommend that if your doctor is starting you on an ACE inhibitor, that you follow up with a routine check in a week or two to see how your creatinine level is doing. Another thing you might want to consider is if you're diabetic and you've started on metformin, if your kidney function deteriorates or your creatinine goes up after starting on metformin, that's something that your doctor or provider is going to want to address and may possibly take you off. One of the things we didn't include on this slide that I want to talk about is acute kidney injuries. Acute kidney injuries can happen to anybody. Acute kidney injuries result when something happens, and not necessarily an insult to the kidney, but something like a dehydration, a cardiac arrest, liver failure, shock, a strep infection, some kind of obstruction, causes that kidney to acutely deteriorate in its function. Now, the kidneys can decide to do three things. There's really no rhyme or reason on what they're going to do. There's no magic pill that we can give you to fix an acute injury. We support everything else. If you have a heart problem, they do the cardiac cath. If you have dehydration, they'll hydrate you. If you're in shock, they'll support everything else. But there's no thing specific that they can do for your kidney. So your kidneys will either recover to their previous level, they may recover some of their function, or they may not recover any of your function. And patients who have acute injuries are more likely to progress to chronic kidney disease in the future. Boy, I sure talked about all this already. So diabetes and hypertension control factors. Can you tell what we're really harping on with you guys? Managing or controlling your blood sugars and blood pressures. slow the progression of kidney damage. I cannot emphasize this enough. This is one of the big things that I am constantly working with my patients. Get your hemoglobin A1C down, work with your doctor, work with your dietitian. Good contact with them, best thing you can do for your kidneys. Managing your blood pressures. We typically want to see where patients' blood pressures are about an hour or 2 hours after they're taking medication. And we want your blood pressures to be controlled. Long-term insult to those nephrons from high blood pressure or diabetes are what causes chronic kidney disease. And patients with diabetes, I do want to let you know, we typically don't see damaging effects to the kidney. I don't see it, at least, until about 10 years after you've been diagnosed. So, you were probably pre-diabetic before that. You've been diabetic for about maybe 10 years. That's when we will see your kidney disease start to progress. And then I've also seen where once the kidneys start to progress towards being diseased and sclerosed, they progress fairly quickly. So, good control of both your blood pressure and your diabetes. Medications, we talked about that a little bit, limiting NSAIDs. One of the things I want to talk about here as far as medications is caffeine intake. Caffeine intake can be both a diuretic. It can also cause vasoconstriction of your blood vessels, which can lead to high blood pressure. So let's talk about lifestyle changes. Yes, they're hard, but we're all here to keep ourselves healthy. Diet. There is no specific diet that you can have to protect your kidneys. We want you to follow a heart-healthy diet, follow low sodium if you need to. We want you to follow your diabetic diet. There's no diet specific for prevention of kidney disease. Exercise, cardiovascular exercise, walking. I tell my patients, walking is going to help you lose weight. And when we talk about that glomerular filtration rate, the only thing that you can easily change in that formula is your weight. And if you have less body to clean, it's going to make your kidneys a little bit more efficient. One of the things I want to add in on this medication section is supplements. There is no supplement out there. You will see ads for kidney cleanses that is beneficial to your kidney. None of these medications have been FDA approved. The claims on them have not been substantiated by studies. And typically what we see is those cleanses are often diuretics, natural diuretics, that can actually damage your kidney by causing you to be dehydrated. So from a nephrology standpoint, we don't recommend kidney cleanses. Over-the-counter vitamins, fine, but please stay away from the kidney cleanses.
Thank you, Barb, for that wonderful education. We've tried to cover all the main points for you tonight. So now there's resources for you if you have questions. As Barb stated, please, please, please use your healthcare professionals as references for your questions. That means your doctors, your advanced practice nurse prescribers, your physician's assistants, and even your registered nurses. Your local kidney foundation is here for you. They have many resources at their disposal. They can help you and guide you where you need to go. The National Institutes of Health, you can see that I've listed the web links or the websites on this slide. Also, the United States Department of Health and Human Services. Some of the information that was in this presentation was from the National Institute of Diabetes and Digestive and Kidney Diseases. One thing when you're surfing the web, please be careful of the websites you use and the resources. Make sure they're good websites. A blog might be just a blog, but if you see something that's from the National Department of Health and Services, you know that's reputable. If you see something that has Mayo Clinic or something that has the National Institute of Health, please, please be careful what references and resources you use. So in this presentation, I've included some brochures or education that's available from the National Kidney Foundation. If you contact the National Kidney Foundation here in Milwaukee, you can obtain copies. So as you see, there's one for GFR. Barb talked about that. One, are you at increased risk for chronic kidney disease and high blood pressure in your kidneys? The next slide, there's a few more. What are the hidden risks for kidney disease, diabetes, and high blood pressure? And nutrition and chronic kidney disease. and diabetes and chronic kidney disease. Please feel free to ask for these free references. And the website I was talking about from the National Department of Health and Human Services, so this is just a snapshot of what it looks like. It's written in easy language, and you can see on the left-hand side, you can pick whatever you'd like to learn about. So this was one slide, and here's another one, how your kidneys work. Like I said in the beginning, kidneys are mighty, they're small, and individuals really don't know much about their kidneys besides they make urine. So if you're unsure and you need information, there's information available for you. So with that being said, I thank you for your attention, and now we will open it up for any questions you have for us. Thank you for your attention, and have a good night.
Changed anything, but
Can you guys hear me? Yeah. Okay, sorry about that. Let's start over. So we're going to talk about questions now. Mary, for emailing in a question earlier this afternoon, definitely made me think a little bit. So her first question was, how does polycystic kidney disease align with chronic kidney disease? So we talked a little about that. I tried to hit on that when we talked about the stages of chronic kidney disease. Polycystic kidney disease would start off as a stage 1, where there's kidney damage. The cysts form on the kidney. They ultimately leak protein and blood into the urine. That's usually typically how it's found. A patient goes to the doctor, routine urine is found, done. They find blood in the urine. Ultrasounds are done. They see the cyst on the kidney. So polycystic kidney disease initially starts at stage 1. I'm going to skip to her other question, which says, could someone stay in stage 1 or 2 for polycystic kidney disease for a lifetime, or is it always progressive? In my experience, it is always progressive, although it progresses much slower than, say, a patient who has hypertension or diabetes. So typically, polycystic kidney disease will ultimately result in a patient needing dialysis down the line. Typically, the patients that I've worked with were in their, I'd say, late 50s to early 60s. So definitely good nephrology care, know about your treatment options, keep yourself healthy so that you're eligible for transplant. And transplant, that's a whole other discussion that we can have. So Carrie's next question. Any new study information on the correlation of kidney disease and heart disease? Heart disease, leading second cause, high blood pressure of kidney disease. So heart disease causes hardening of the arteries. Those hardening of the arteries affects the capillaries within the glomeruli. Those glomeruli become sclerosed. Those nephrons ultimately die. Kidney disease progresses. This was the one that really got me thinking. Any specific studies on SCAD, which is spontaneous coronary artery dissection, heart attack, and kidney disease? So spontaneous coronary artery dissection is a decreased flow to the heart due to a tear in the blood vessel in the heart. This is about 40% of heart attacks in women under 50 are thought to be resulting of this spontaneous coronary artery dissection. So how does this relate to coronary or to kidney disease? I would say, I couldn't find any hard and fast studies, but from the literature I looked at, it's going to be problems with volume depletion. If a patient or woman is bleeding out and she goes into shock or has a decreased volume in her blood vessels, that's going to cause your blood vessels to clamp down. You're not going to get enough blood going to the kidneys, and that's going to cause an acute kidney injury. Usually it's called acute tubular necrosis. And anybody can get an acute tubular necrosis from a dehydration or, if you have bad diarrhea or vomiting from a stomach flu, you can give yourself an acute tubular necrosis or an acute kidney injury. And what you would typically see is that your urine would be something we call cola color. So your urine would be a dilute brown color. So I would suspect that the correlation is that acute kidney disease can be the result of this SCAD heart attack. And then her final question was, how long does the average person stay on dialysis? And that is kind of a difficult question to put a hard and fast number on. I tell my patients average of about 6 to 10 years. I've seen patients on dialysis for 20 years, and I've seen patients on dialysis for a year. It really depends on how healthy you are going into dialysis, how healthy you keep yourself on dialysis, how you follow your doctor's orders. Do you stay for your full dialysis time? Do you take your blood pressure? Do you follow your dialysis diet? Are you eating a low potassium, low phosphorus diet? All of that plays a role in your overall health. The older you are, patients who go into dialysis who are in a wheelchair already starting to be a little malnourished, they're going to have a shorter life expectancy. A younger person who's, has maybe a polycystic kidney disease is going to do much better on dialysis because they're going to be younger and hopefully have a better chance of getting a transplant. But the average life expectancy, about 6 to 10 years. But like I said, that it has so many variables to it. So right now I'm open to any other questions and invite you to submit them.
And here's a list of our references. And we really wish to thank Cindy for inviting us to present today. So as Barb said, we're open to any questions that you might have.
And here in the room, Merle is doing some adjustments, but if you don't have a microphone on your computer, you can type them in. But Merle, is anyone that, are you seeing any questions? All right. Well, I want to, first of all, thank Judy and Barb for coming tonight. I think it was, it's clear that both of you worked really, really hard on this presentation. I was listening, and even I went, really? And on some things that I didn't know. So, and I have the opportunity to listen to professionals a lot throughout the year. So I know how much hard work you guys put into this, and I know the folks listening to this really do appreciate it too. We're honored that we could contribute to the awareness about chronic kidney disease in all the countries throughout the world. And I'm very happy to say that this presentation, the slides as well as Barb and Judy's presentation has all been recorded and will be on the National Kidney Foundation Wisconsin website. So Merle and John for their technical assistance tonight. We couldn't do it without volunteers. And I want to thank all of you for listening and being with us tonight. And remember, the National Kidney Foundation of Wisconsin is always available as your resource to connect you to the next set of resources. So thank you very much for joining us. Good night.